Good evening and welcome to the second ERS Vision Live panel discussion, featured exclusively on the ERS Respiratory channel. Today's discussion will focus on living with rare respiratory diseases during the COVID-19 pandemic, looking at the experiences and learnings of leading specialists and patients since the outbreak began and how the field has adapted to respond to the health crisis. We are delighted to welcome today's panel, which brings together leading figures in the field of rare respiratory diseases, led by ERS President-elect Professor Marc Imbert. Marc is a professor of respiratory medicine at the Université Paris-Saclay in France. He has also been vice coordinator of the European Reference Network for Rare and Low Prevalence Respiratory Diseases, or ER and Lung, since 2017. Marc is the director of the Department of Respiratory and Intensive Care Medicine at the French Pulmonary Hypertension Reference Centre. He is also a past chief editor of the European Respiratory Journal. His research interests focus on rare lung diseases and pulmonary hypertension. Good evening, Professor Imbert.
Good evening, Maeve, and thanks very much for the kind introduction. Firstly, welcome everyone joining online this evening to support this new European Respiratory Society initiative. We welcome any questions you wish to put to our guests tonight and the panel this evening. So joining me on the panel will be my colleague and friend, Professor James Chalmers. James is the GSK British Lung Foundation Chair of Respiratory Research at the University of Dundee in Scotland and an honorary consultant physician at Nine Wells Hospital. His clinical and research interests are in difficult airways disease, particularly bronchiectasis and COPD. Welcome, James.
Thank you very much, Mark, for the kind introduction. I'm looking forward to a lively discussion this evening as we dig into some of the issues that patients with rare lung diseases have faced during the pandemic.
Thank you so much, James. And our first guest this evening is Mrs. Pisana Ferrari. After her double lung transplant in 2002, she has also been very active as a patient advocate for pulmonary hypertension and for organ donation and transplant in her own country. She will be sharing personal experiences from the emergence of the pandemic and how it affected her life as a patient needing careful follow-up and highly specialized care. Welcome, Pisana.
Thank you, Mark. And thank you very much for giving me the opportunity to present the patient perspective at this very important meeting. Thank you.
Thank you. So, Pisana, could you tell us a little about the reactions you experienced in protecting yourself from the virus and the increased reliance of remote monitoring?
Yes, of course. Well, last year, as the reports were coming in from all over the world about COVID-19 and the complications for the lungs, like pneumonia, oxygen intubation, I was getting increasingly worried. Having been through all that already during my years with PH and after my lung transplant. And of course, I knew that if I caught it, it could be deadly. So during the first lockdown, I was at home for 2 months without ever going out or seeing anybody. At the time, it was impossible to get any groceries delivered as everybody was doing the same thing. Luckily, there were volunteers in my town taking care of people like myself. I missed one medical checkup in Bologna because we were not allowed to leave the region I live in, and also because of the risks. And I had to postpone surgery twice and eventually had to have it in the middle of the second wave in the winter of 2020, which was not ideal, but I couldn't wait any longer. It was risky. I had to take a train, stay in a hotel, spend some time in a hospital. In any case, ever since the first lockdown, I've been very, very cautious. I have gone out very little and see very few people. And I've been in touch with other patients and they've had very, very similar experiences.
Thank you very much, Pisana, for sharing that with us. It's really important to be able to communicate these difficulties with all of us. So let's move a little bit to another question. So have access to medicines been constant during this crisis? And what are your thoughts as a patient on the development of vaccines?
Well, that's a very important topic. Actually, I almost ran out of one of my immunosuppressant drugs, which is very important because I could only get it in Bologna. For the other medicines, access was not affected in the town I live in. They were also delivered by volunteers. On the issue of vaccines, I have to say that I was worried because I could see people were pushing governments to provide them. Governments were pushing pharma companies to produce them. And pharma companies maybe wanted to be the first ones out with something. So my fear was that there might be some shortcuts somewhere down the line, and also that the long-term effects would not be known at the time it came out. And now, even now, today, the news in the media about vaccines is very worrying, to say the least. We're getting a lot of calls from people on the Italian Association's helpline. They are very scared and they're desperately looking for guidance. Italy is lagging behind and each region is doing its own thing, which makes it even worse. I have personally no idea when I'm going to be, next on the list for vaccines. And I know that PH is it's not on the priority list. So unless we manage, and we're trying to do something via the association to have them included in the fragile patients category, we'll see how it goes.
So, Pisanna, we've clearly learned a lot during this pandemic. Do you feel that we'll be better prepared should we experience future pandemics? And from your perspective, what do you think are the key lessons that we've learned as a patient?
Well, I think we're all better prepared in the sense that the first time around, we couldn't even get any masks or disinfectants or anything. Also, some of the hygienic norms by now have been, let's say, internalized and have become routine, like wearing masks, washing hands, distancing. I am personally getting better organized at home. I have stocks of all of that and food. But what is mentally challenging is to be in and out of these red zones, as they're called in Italy, all the time and at very short notice. We had a change of government also in the middle of the pandemic. So really, you need to learn to be flexible and take one day at a time. It's difficult. I was already working remotely, so that was not affected too much. And I have no children still at home, but it's a tough and scary time for everyone, and all the more so for people with lung diseases, given the very high risks.
Thank you, Pisanna, for once again sharing all these feelings and experiences with us. So we are going to have a brief first panel discussion. We'll try to have discussion throughout the show tonight. And maybe I would like to know, you currently mentioned that sometimes transportation is no longer possible between regions in your country. And I know it is the case also in other countries, and it is very frightening. As a patient representative, do you try to have free travel permissions for patients in need of specific managements?
Well, actually, I'm in Bologna right now for a checkup, and I had to have a paper made, especially by the transplant day hospital, so that I would be allowed to travel on the train. Actually, nobody asked me, but I was prepared in case. And I know they're doing it systematically for everybody. So that's something that can be, it's allowed for serious situations like health reasons and work that can't be, let's say, postponed.
Thank you. James, do you want to address one question?
Yeah, so Pisanna, you made the very important point about the anxiety that many patients are feeling around vaccines. So I'm wondering if you have any thoughts around what we could be doing better with communication around vaccines, which is clearly a very important topic around Europe at the moment.
I think the real problem is that there's so much conflicting information. So people are confused. One day, one vaccine is not to be used for over 65, the next day for nobody. Then it's fine for everybody. I think there's really been a communication problem, probably EU-wide. Could have been handled better because, of course, all of this uncertainty affects patients who are already very scared of what could happen to them. They have no idea when they're going to be able to get a vaccine, and it's difficult. The communication is not being as good as it should have been, or could have been.
Yeah. And clearly the anxiety far greater if you have an underlying lung condition that you already feel a great deal of anxiety around COVID-19.
Of course. I know one lady whose husband moved out because he had to continue to work, and she's been living alone for a year because he had to work and he didn't want to endanger her in any way. And these are things that are happening.
Yeah, thank you, Pisana. We will have more time to talk together later tonight, but we have to move on, and I'm delighted to hand over to James for the next section. Thank you.
Thank you.
Thank you very much, Mark and Pisana. So we're going to move now. I'm delighted to introduce our next guests, who are Professor Isabelle Fajac and Dr. Clémence Martin, who will share with us the results of a European survey on cystic fibrosis patients who had COVID-19 during the pandemic from spring until now. So Isabelle Fajac is a doctor in respiratory medicine and a professor of physiology at the University of Paris, France. She's worked on cystic fibrosis for nearly 30 years and is president of the European CF Society. Welcome, Isabelle.
Good evening, and thank you, James, for the kind introduction, and thank you for the invitation. I'm very happy to be here with you to talk about this important issue.
Fantastic. And Dr. Clémence Martin is an assistant professor in respiratory medicine and a member of the Adult CF Centre at Cochin Hospital in Paris. It takes care of more than 500 adults with cystic fibrosis and is the biggest adult cystic fibrosis centre in France. Welcome, Clémence.
Good evening. Thank you for the invitation. I'm really pleased to share my experience in cystic fibrosis with you tonight.
So thank you so much, Isabelle and Clémence, to be with us tonight. So I will start with a question maybe to Isabelle. Isabelle, respiratory viral infections are usually more severe in cystic fibrosis patients than in the general population. How is it for COVID-19 in CF patients?
Yes, you're right. So we needed from the beginning to understand how it would be for patients with cystic fibrosis when they were ill with COVID-19. So we implemented a survey. This was implemented as early as last April. To do so, we used the European registry that we manage at the European Cystic Fibrosis Society with the help of some national registries. So we set up a questionnaire, and it was disseminated to our centers, to cystic fibrosis centers from 38 countries. And with this, we have the feedback of nearly 44,000 patients with cystic fibrosis. And since last April, we had 900 patients with cystic fibrosis who were reported to have been ill with COVID-19. I'm happy to report that most of the cases were mild disease or even asymptomatic COVID-19 disease, but we report 30 very severe cases and 13 deaths. And clearly the main risk for patients with cystic fibrosis to have a very severe COVID-19 disease is when they have immunosuppression due to organ transplant.
Thank you very much. And I'm sure many CF patients will find much of that very reassuring. In terms of the next question, what do you think have been the main changes in care management or drug delivery during the lockdown? And do you think that what do you think are the similarities or differences for adult versus child CF care during the pandemic?
I think I'm gonna answer this question because I have this experience of physical doctor with the patients, and actually there wasn't much differences between adulthood and childhood in the management of the cystic fibrosis due to the outbreak. Cystic fibrosis involves early chronic bronchial infection. So patients are educated from early childhood in regular hand hygiene, routine facial mask use, and social distanciation when they attend visits to CF centers. So when the COVID pandemic started in France, they applied preventive measures very easily, spontaneously, and they were even pleased to teach and explain good practices to their relative as expert patients in these practices. Then the management, well, as in the other European and countries in the worldwide and all CF centers, we put rapidly in place the remote monitoring of patients. The patients was really scared at the beginning. You know, when listening to Pisana, we heard exactly the same thing when during the first wave, because they were very scared about viral infection and what it could have in consequences to their clinical status. So they really understood the necessity of remote monitoring, and during the outbreak, and especially during the country lockdown. What we saw, that what we feared is that they would have a lower access to drugs, and also they would lack of physical activity during the lockdown. And to our surprise, patients declared that they had more time to dedicate to the treatments and especially to physical activity. Pharmacists were told to renew outdated prescriptions, so they didn't lack any medication during the lockdown. But on the other hand, they had no longer access to respiratory physiotherapy session, which is very important during cystic fibrosis. And we had no longer access to the opportunity to monitor spirometry measures during follow-up. What we feared also is that during cystic fibrosis, they often need IV antibiotic courses organized at home. And we feared that it would be more complicated during lockdown. And overall, it was more difficult than in normal times.
Thank you, Clémence. That's really interesting. And can you tell us if the lung transplantation program has been disturbed by this outbreak?
Well, indeed, during the outbreak in France, even more in the northern part and eastern part of France, all intensive care unit beds and recovery rooms, and sometimes even operating rooms were dedicated to COVID patients. So as a result, during 2020, the number of lung transplantations for all respiratory diseases was decreased by 25%. But when we looked really specifically on cystic fibrosis patients, well, the decrease in lung transplant in confronted to 2019 was even more important and reached about 50% of decrease. This very important difference was not explained only by COVID pandemic, but also that luckily at the very beginning of 2020, the majority of cystic fibrosis severe patients gained access to a very effective novel drug association that enabled these patients to stabilize their clinical status and respiratory function, and they could, in this case, delay their need for lung transplants.
Yeah, so new treatments clearly making a big impact on the field of cystic fibrosis. A question now to Isabel. What's the approach at the moment for vaccination at your centre for adult CF patients?
So in France at the moment, vaccination for patients with cystic fibrosis is recommended for those at risk of a severe COVID-19 disease. That means patients with immunosuppression due to organ transplant, or with CF-related diabetes or cirrhosis or advanced lung disease. But I have to say that these recommendations are not always followed, because the main issue is access to vaccines, as we all know. So some patients get vaccinated through some channels that we don't know really about, and they do not really fit these recommendations. And other patients that would really need the vaccination can't have access to it because it's restricted, very restricted at the moment. So we hope for a better future in the next coming weeks for this.
The same problem that we're seeing all across Europe, also affecting patients with rare lung disease. We're going to move now to the second panel discussion, and I'll kick things off by asking you first, Isabelle, and then Clémence, please come in. Were you surprised by the results of your survey? Did you expect that CF patients might be more severely affected than they were?
Yes, to be honest, we thought that maybe they would be more at risk to get ill with COVID-19, and that, well, they had already, for some of them, for adults at least, a lung disease. So we thought they would probably be more affected. And it was really very quickly in April during the first wave and even March, we saw very few cases. So within a few weeks, we were a bit reassured about this. But it was a surprise, yes.
Yeah,
And
it was a
Clémence, anything to add?
Yeah, it was really a surprise. And at the beginning, we actually thought that it was because of the fact that they were used to social distancing, that they were used to wear their mask, and that they would be really very thorough in the hand wash and everything. So we thought that it was due to that they did less COVID problems, because they actually had less, they were less exposed. And actually, we realized that it was not only that, but because we really found a lot of people with asymptomatic infections when we looked for them. So we were really surprised, and we were happy to see for once that cystic fibrosis had a good response to a viral respiratory infection.
Yeah, and I'm sure the cystic fibrosis community really appreciated having some reassurance at such a difficult time. Mark, any questions you'd like to ask?
Yeah, maybe a brief one. What you describe is mostly an analysis of the first wave of COVID-19 pandemic. Now we are at the third one in Paris. We live in the same town. Do you have the same feeling? The third wave will lead to the same conclusion? The patients are not more likely to be infected with the more contagious variants, etc. Do you have any recent data to share?
In fact, the survey is ongoing. So we began in April, but we still get results every week or every other week. So the 900 patients that I've talked about include all patients from April to March. And I don't think that we've seen more patients during the second or the third wave. To be honest, we don't know, of course, about the variants and their impact on patients with cystic fibrosis. I think that on the whole, as we know, age is a major risk for severe COVID-19, and patients with cystic fibrosis, well, they are all, most of them, they are very young, or young adults or children. So it's probably one explanation for the relatively mild disease that they do when they have COVID-19.
Thank you. Thank you very much, Isabelle and Clémence. That's very, very interesting, very reassuring.
Thank you.
So, and I'm going to hand over to Mark for the next session.
Yeah, thank you, James. And don't leave far away, because it's your turn now to be on the spot. So it is time to discuss with you and with Dr. Pippa Powell to discuss recent events in non-cystic fibrosis bronchiectasis. So we move to another condition. So Pippa Powell is a director of the European Lung Foundation, the ELF. ELF works to ensure people living with lung disease have access to evidence-based information and the opportunity to influence respiratory research and guidelines at the European level. And we really wish to have Pippa tonight with us, because we are really in a partnership tonight between patients, families, and doctors. So welcome, Pippa.
Thanks very much, Mark. Lovely to be here.
Thank you so much. So you have organized a major patient congress on bronchiectasis. How difficult was it to organize such an event in such a difficult time? What was the feedback from the patients and from the carers?
So yeah, it was a difficult time to arrange, and it was our first ever patient conference, Mark. So, this wasn't something we'd done before. So we thought it would be a really challenging time to do it, but it was actually a really good time to do it. Firstly, online opportunities have increased dramatically. So rather than trying to bring patients physically together, we were able to use new technologies to bring them together online. Secondly, we had an amazing group of bronchiectasis patients who felt really at a loss of what to do during the COVID-19 pandemic. And they felt that holding this conference and driving this conference for fellow bronchiectasis patients was a really important thing to do and really gave them some focus and drive. And also we had some fantastic healthcare professionals and experts in the field of bronchiectasis, specifically through the Embark CRC, who were really willing and able, even in this really difficult COVID time, where their time was really limited, to answer all the questions from the patients. And the conference was really patient-driven. So all of the content of the conference was designed and produced by the patients. They asked the professionals what they wanted the answers to, and that's what the professionals talked to. So it was a really great new way of doing things, and I hope it's something that we can continue to do in the future. As to feedback, again, it was really fantastic. So this was a pilot, as we'd never done it before, but we actually had 1,500 patients register, more than 800 patients there on the day, and more than 1,000 patients who've already watched the recordings. And I think one of the key things is we're getting feedback that says things like, I've waited my lifetime for this kind of information, and it's really changed the way that I'm going to deal with my disease. And finally, the thing that really made the conference fantastic and interactive is that there were more than 500 questions posed during the day by individual patients to the experts who were speaking. And the experts spent the whole day answering those questions. So I think patients really felt for once that they got direct access to experts and could have their questions answered.
Thank you, Pippa. Very exciting information and many congratulations for this achievement. So let's move now to the clinician, James. We just discussed CF. We had a discussion also with a patient who was transplanted. Do patients with known CF bronchiectasis carry a specific risk when infected with SARS-CoV-2?
So it's a really important question, Mark, and it's one that patients really wanted an answer to at the beginning of this pandemic. Pippa's done some amazing work with her colleagues in the European Lung Foundation, as you've just heard, but also in answering questions from patients via their website during the pandemic. And this was probably the most common question we got from bronchiectasis patients. How much more at risk are we? There's now 2 studies, one from China, one from South Korea, that show a slightly increased risk of poor outcome, hospitalization and mortality in bronchiectasis patients compared to age-matched controls. So there does seem to be a slightly increased risk. On the other hand, my own experience and the experience of many other clinicians in Europe is that similar to the CF experience we heard from Isabelle and Clémence, is that patients have been very used to protecting themselves from COVID-19. And so the numbers of patients that have been infected in our experience has been quite low because these are patients very experienced in keeping themselves safe. So I think, again, the message would be quite reassuring to bronchiectasis patients that their risk is not markedly increased.
That's very good to hear. Very, very good information and quite reassuring. Regarding your own work in your clinic, how did you organize yourself during the pandemic? Can you share with us some recommendations for the daily management of severe respiratory patients during the outbreak?
I think all of us as respiratory physicians have been struggling during this period to deliver high quality care to patients during a period when we can't always see patients face to face. And so what we've had to do is adopt new technologies. So we've been doing video conferencing, with patients to do their outpatient appointments. One of the key components of the management of bronchiectasis is airway clearance chest physiotherapy. And so finding ways to deliver that virtually, so providing access to high quality video content, for example, and demonstrating and training patients through video link has been really important. So we've managed, I think, to deliver the core components of high quality care, but so far as possible in a virtual and a safe environment. In many ways, I think the pandemic has forced us to adopt new technologies that we should have been using more often, even before the pandemic. And so it may have a long-term benefit to the way we deliver care to our patients.
Fantastic. Thank you very much. So we are going to chat a bit, the three of us. So Pippa, I'm really excited to see the outcome of your virtual meeting you organized with the patients, James and Mark. What is your next objective? Even if we go out of this pandemic, is that going to stay for a long time, these virtual conferences, even in peacetime?
I think for sure it has some huge advantages for respiratory patients. Not having to travel is a big factor. And I think it allows for more flexibility with language and things like that. So one of the issues with the bronchiectasis conference, well, not an issue, but one of our challenges is that it was limited to English language. And we're already working with some of the Embark colleagues to actually now deliver the conference or a similar or a version of the conference at the national level in national language. And again, I think, virtual and online makes that much more feasible and much more possible. We'd also like to look at different topics, other areas where there's information lacking. So at the moment, we're thinking about long COVID and the fact that, there's so many unanswered questions about long COVID, and there's so many patients who wouldn't be in patient organisations getting reliable information that perhaps we can serve in that way as well. But I think there is still a place for face-to-face contact, and we'll certainly still welcome our patient organisations to the ERS Congress every year, because I think they hugely value that as an opportunity. But yes, I think COVID from a digital perspective has brought lots of opportunities.
All right, so thank you. We have seized the opportunity, and I think you did very well, James and Pippa. Well done. And now I'm handing over to James to follow on.
So thank you very much, Mark. So we're moving to another disease now. Earlier this week, Mark Humbert met up with Professor Vincent Cotin for a discussion on the severity and outcomes of COVID-19 patients on the outcomes of COVID-19 in patients with idiopathic pulmonary fibrosis. Vincent Cotin is Professor of Respiratory Medicine at the University of Lyon in France. And since 2017, Vincent has been the coordinator of the National Reference Centre for Rare Pulmonary Diseases in France.
Hello, Vincent. Your reference center in Lyon is in charge of patients with rare respiratory diseases, often living quite far from your institution. What was the impact of the outbreak of COVID-19 on the care of patients with ILD during the spring 2020?
The outbreak of COVID last year took us somewhat by surprise, and there was a lot to learn in very little time for both the hospital directors, the doctors, but also for the population and the patients as well. And one positive learning was to set up consultations by telemedicine, but the patients do not appreciate them so much. They sometimes tend to consider them as fake consultations. So we do a mix of consultation in presence and by telemedicine. And we've also learned how to reorganize the departments in a very short time, which was not a given in the public hospitals before the pandemic. And we've also learned to better communicate with the patient through our website and with the help of patient association. However, one dramatic consequence was that we had to temporarily interrupt our transplant program. And this was mostly because most of the resources, and especially the anesthesiologists, had to be reallocated to the care of COVID in the ICU. And we also had to postpone most of the research activities last year. But these activities, research and transplant, are back on track now. But also for the monitoring of patients, the regular follow-up with pulmonary function test has been a little bit disorganized and decreased in volume. And everywhere, I suppose, it is challenging to come back to normal care when regularly facing a new wave of COVID.
So you play indeed a major role in the management of rare lung diseases in France, and the patients with interstitial lung diseases, they may be at higher risk of worse outcomes when infected with SARS-CoV-2. Can you share with us the main conclusions of your recent report entitled Risk Factors for Mortality After COVID-19 in Patients with Pre-Existing ILD?
Yes, indeed, we were really concerned for our patients with fibrotic lung disease. And before our survey, there were 2 studies showing an increased mortality in patients with interstitial lung disease as compared to patients with no interstitial lung disease. But you very well know that in terms of COVID, for prognosis, you have to consider a lot of different factors: the age, the sex, comorbidities, the severity in this case of interstitial lung disease, and whether they were receiving antifibrotic or immunosuppressive therapy, depending on the disease. What we've done was the study specifically for patients with fibrotic lung disease, using a survey throughout the specialized centers in France. And we found a mortality of 19% in patients with non-fibrotic lung disease, interstitial lung disease, as compared to 35% of mortality among those hospitalized for COVID who had a fibrotic interstitial lung disease. And the particularity as compared to other studies is that we could have access to the lung function and to the particular diagnosis. And we found that by multivariable analysis, the risk factors for mortality in these patients were age, male sex, to have comorbidities and especially a history of cancer, and to have a very low lung function and to be on oxygen already. And therefore, the message of this study was that the pre-existing interstitial lung disease and the treatment received are generally confounded by age and sex. They are not independent risk factors for these patients. What is important is age, sex, and comorbidities.
So to close, I think 2021 is still difficult and COVID-19 is still a threat to our patients. Where are your patients with interstitial lung diseases prioritized for COVID-19 vaccination?
Well, yes, indeed they are. And this was a major consequence of the study that we've conducted in France, because patients with fibrotic lung disease are at high risk, and those with IPF in particular. And we know that now. When the French Ministry of Health needed to prioritize subgroups of the population for the vaccination, the results of this study were instrumental to list patients with pulmonary fibrosis as high priority for the vaccination, even those younger than 75 years of age. So currently they are either vaccinated or listed to be vaccinated as soon as possible.
Thank you very much, Vincent, for sharing with us your experience in those difficult times. I hope to see you very soon with very good news for our patients with rare respiratory diseases. And we hope to have better news in the future to share with the community.
Thank you, Mark. We're working on that.
Thank you, Vincent. Unfortunately, you couldn't be with us tonight, but I think the recording was quite interesting. And to help us further analyze the discussion with Professor Vincent Cotin, I would like to welcome Professor Caterina Antoniou. Caterina is Associate Professor in Respiratory Medicine and Head of the Molecular and Cellular Pneumology Laboratory at the School of Medicine, University of Crete in Greece. We have some connection issues with Katarina. Can we hear you, Katarina? Hello, Katarina.
Hello, Mark. Hello, everybody. And thank you for the invitation. And I'm glad to participate in this very important meeting.
Thank you. Thank you so much for being with us. We know some technical issues can happen, and we can hear you very clearly. So that's really nice. So Katerina, how was the situation in Crete? And did you experience a similar challenge than Vincent Cotin in Lyon?
Fortunately, we didn't have the same experience in Crete because of the early lockdown in Greece, which gave us the possibility to reorganize our clinics, the outpatient clinics for ILD and for rare diseases. In Heraklion, we are a referral center for the whole island of Crete. So we had a little bit of space regarding to reorganization of our activities. So we continue our outpatient clinics with rare diseases diagnostically and to offer our patients the possibility to diagnose and to have access to their medication, prescribing, etc. And this is, I think, was an important issue. And we published the national experience from the early lockdown in Greece, in ERJ, stressing actually the beneficial effect of the early lockdown. But now we are in the third wave, and we see now patients come back with in the post-COVID era after the second wave, with in the ILD clinic also with interstitial abnormalities, and we have to take care also of these patients. And as you know, as a respiratory society, European Respiratory Society, we try to have an organization regarding the follow-up of patients with chronic respiratory diseases, and we are working on that within our society.
Thank you, Katerina. It's really nice to hear that we are active and we propose new actions through the ERS. So I know many of you have asked questions, and James has access to the questions and is going to follow on.
Yeah, it's fantastic to see how many questions there are this evening. A reminder that you can ask questions through the Slido. So, Katerina, there's a number of questions that have come in around ILD. I want to ask you one first, because it's come from both the patient organizations for IPF, but also sarcoidosis, and several other questioners have asked, is there any particular vaccine that should be recommended for patients with ILD?
We recommend every vaccine, and our population, our ILD population should be vaccinated as soon as possible. And I think this should be a priority for every government, and we do that in Greece, especially for ILD people, patients. We know that fibrotic disease, yes, we know that from recent study and from other studies, international studies, that fibrotic patients are in major risk if they are hospitalized or intubated. And there is a very recent JAMA paper from University of Marca, which stresses out the multidisciplinary, the multifactorial risks after severe COVID. And one of the risks is the fibrotic disease in a high percentage of patients without interstitial lung disease. So you understand, we all understand that when we have a viral trigger altering the host microbiome of our patients, are in major risk in combination with the valley from the mechanical intubation. So one more pathogenetic link between COVID, long COVID sequelae and fibrotic diseases.
Yeah, very good. So that's what I've been saying to my patients as well, that the best vaccine is the one that you can get into your arm as quickly as possible. So it's good to hear you have the same opinion. One final quick question with a quick answer. Carly Gilbert has asked whether there's any data on children with interstitial lung disease and how they fared with COVID. Is there any data?
No, I'm not aware of any data regarding children with ILD. Maybe other colleagues are more aware about that, but I don't have an answer for that.
And there are many areas of the impact of COVID where we just don't have high quality data. So thank you, Katerina.
So we need, yes, we need more data, more trials, and maybe antifibrotic treatments should be continued. The patients that are under antifibrotic treatment should be continue to be on these treatments, which may have beneficial effects also in COVID, after COVID ARDS disease for pathogenetic reasons. So try to have our patients under their medications.
Thank you, Katerina. Very clear statement, and stay with us. We will have a general panel discussion at the end, and we will cover some questions which have reached us for the final section of the show. So now, James, the floor is yours for the next session.
Thank you very much, Mark. For our final discussion, focusing specifically on a rare respiratory disease, I'm delighted that we're joined by Professor Marion Delcroix and Professor Gergely Meszaros. Professor Meszaros is a graduate economist, tax advisor, and lawyer who has more than 17 years' experience in the banking sector as an attorney at law. He's been active in the pulmonary hypertension community since 2010 as a board member of PHA Europe for 2012 to 2013 and 2014 to 2015, and as a staff member focusing on advocacy work since then. So welcome. Thank you for joining us this evening.
Good evening, and many thanks, James, for the kind introduction, and it is a pleasure to be here in this pleasant discussion.
Thanks for joining us. And Marion Delcroix is Professor of Medicine and Respiratory Physiology at the Universities of Leuven and Kortrijk in Belgium. She's the head of the Pulmonary Hypertension Programme and chair of the Council for Rare Diseases of the University Hospitals of Leuven. She's also assembly head for pulmonary vascular diseases of the European Respiratory Society. So thank you for joining us this evening, Marion.
Thank you very much, James.
So can I start with the first question to Dr. Meszaros? You have organized a patient survey based on a set of questions translated in many languages. How did you organize the survey?
Actually, it was a real teamwork. We finalized the English version with Professor Marion Delcroix and her team relatively fast. And that point came in the fellowship network and international connections of PHA Europe, and resulted in altogether 16 language versions. Following the validation of these language versions by local physicians, we received the valuable assistance of ERL Lung in generating the links to and collecting the data from these surveys. The questionnaires were advertised within the PH community, and we managed to collect more than 1,000 responses, which is an excellent result for a rare disease.
Indeed, it's an excellent result, Gergely, and I was so pleased to see that you were able to provide the survey in the native language of your patients and carers. So, Marion, in parallel, you organize a PH specialized center survey. What are the key messages of your survey from specialized center? And did you see a difference between pediatric and adult centers in charge of PH in your survey?
So yes, Mark, so similarly to what Clémence told us about the patients with cystic fibrosis, the COVID was not the disasters we had expected for our patients. So the survey, which was organized during the first waves of the COVID with the support of the ERS, involved 47 centers out of 28 countries. And it confirmed the diagnosis of COVID in 70 patients, which is not so much if you consider the thousands of patients who are normally followed by these centers. They were, majority of them, pulmonary arterial hypertension, a few with chronic thromboembolic pulmonary hypertension. 44 of them were hospitalized, the other were treated at home. 11 were in the intensive care, and 13 died from COVID, which is 18%. It's a figure which is similar to what Vincent told us for fibrotic disease. And so it was also very strange to see that in some countries there were no deaths, in other countries there were up to 50% of deaths in the cases who were hospitalized. And probably this is related also to the age of the patients and also to the covering of the patients and the contact with the patients during the pandemic. The hospitalization was 6 days for the patients, 3 in intensive care units. And we had 83% of the patients who need some respiratory support. The majority of them just oxygen, and 10% were ventilated for the disease. We had no specific data on pediatric centers. Most of the centers we had were adult centers.
Yeah, so that's very interesting. Obviously, things have changed as the pandemic's gone along. Do you think the situation has changed or improved? Maybe Marion, give us your answer first, and then great to hear also what Gergely thinks.
We did not repeat the survey. However, many colleagues report more cases and with a similar outcome. There were, again, a few deaths in the patient they reported. But as many patients with rare disease, our patients became expert in the shielding. And so they protect them incredibly well. What concerns vaccination in the PH patients, they have not been prioritized in many countries, which is similarly to what we heard already. So very few are vaccinated at this point.
And Gergely, what are your thoughts?
Yeah, many thanks, James. So actually, as you might know, the rules are not only varying countries by countries, but regions by regions. And as we understand, the healthcare providers mostly adapted to the situation. In some cases, visits were suspended or postponed, or even the hospitals were closed and solely accepting COVID patients. But nowadays, step by step, alternative e-health days have been introduced in almost all European countries. And also we are aware of nice examples when patient associations stepped in and are bridging between healthcare providers and patients.
Thank you, Gergely and Marion, for these very clear answers to these questions. So Marion, remote monitoring for PH patients. How did you manage that in your clinic? Did you structure remote monitoring? Can you share your experience with us?
Okay, so patients with, I must not tell you that patients with PH can rapidly deteriorate, and therefore they benefit normally from intensive monitoring, continuous clinical monitoring, very frequent consultation at the centers. And so during the COVID surge, the majority of the interrogated centers from the survey developed remote consultation according to a majority of teleconsultation and a few video consultations. They kept contact with their patient in the majority of cases. Concerning the technique which were used, so you know from wearable devices, measuring heart rate, blood pressure, saturation, and also the physical activity of the patient, which is a very important prognostic factors. They are currently evaluated for potential utilization in the risk assessment of patients, but we have not have many data on this practice yet in these patients. Of course, there is also, as we have heard for other disease, webinars are organized to better inform the patients on a very specific topic related to COVID and to others matters. But this is the stage we are there.
So that's all really, really interesting. It's not just really about the clinical care of patients, though, is it? Because pulmonary hypertension is also an area of intense research, and many randomized controlled trials will have been disrupted during this time. What's been the effect on randomized trials during the pandemic? Recruitment on hold, these sorts of issues.
Yeah, indeed, recruitment for PH was completely put on hold during the first wave, and has really difficultly restart since then. In addition, the diagnosis of new patients seems to have be delayed, with less new patients presenting at the centers, also so less patients to include in study protocols. The study protocols have been amended in order to allow the remote monitoring and also safe delivery of the study drugs, which was not evident during the first wave. Some invasive tests, like the right heart catheterization, which is fundamental in our pathology, are delayed. And they have sometimes been the primary endpoint of phase 2 clinical trials. So that's a problem that we will probably need to impute some value of this catheterization, which compromise some of the studies. So it's really a problem, and it's not completely solved yet. We have still centers who are not able to perform right heart cath for the moment.
All right, so that's a bit concerning, of course, but we will, I think, find solutions, because we have demonstrated that we are open to new solutions to these very difficult problems. So now it's time to gather all together. So I invite all the panelists to join for the panel discussion. So good to see all your friendly faces, and congratulations for all the great discussion and feedback from all of you, patients, patient supporters, doctors, researchers. That was really very good. So I would like to start maybe with one question, and maybe James will ask a few of the questions, the many questions we have received on the web. So first question related a little bit to Marion's last comment. So right now, we all work in academic environments, and there are lots of randomized controlled trials devoted to COVID-19. How can we work in rare diseases in that very competitive environment? So I don't know if one of you wants to say in their own disciplines, if they feel that the competition is tough, and if there is any threat for new randomized controlled trials devoted to the diseases we want to focus on. So I don't know if James or Isabelle or Clémence or Marion want to take this question.
I can perhaps give a small answer. During the first wave anyway, these patients were excluded from the vaccine and medication trials because they were estimated to be too severe. So perhaps it will come in the future, but until now it has not been a problem.
Yeah, maybe I was not very clear, but do you think that with the current competition for research unit, clinical research unit, etc., it's more difficult to find a space for our classic randomized controlled trials? So we try to protect ourselves. I know James does the same, and Clémence and Isabelle and Marion and Katharina. So right now, what we try to do, we try to secure our own randomized controlled trials, and we try to have two different tracks, one for COVID-19 randomized controlled trials, but we protect randomized controlled trials devoted to rare diseases, for me, pulmonary hypertension. So maybe, James, you have specific questions from our very lively colleagues.
Yeah, so I have a question that came through on the Slido for Marion, and then anyone else is welcome to comment. There's a lot of data on the involvement of the pulmonary vasculature in COVID. So the questioner asks, do you think that severe COVID is going to lead to more cases of PH, or are you perhaps seeing more cases following the COVID pandemic?
Yeah, there are two aspects that could be related to COVID. We have the chronic thromboembolic pulmonary hypertension with true proximal clots, and that at this time we have not seen many patients presenting because the clots in the COVID are very distal disease, and they may more mimic idiopathic pulmonary hypertension or disease which is very distal in the very small vessels. But at that time, I have no indication that we would see more patients. What we see is more severe patients because they are delayed diagnosis, but that's nothing related to the COVID. However, some patients who have the disease, pulmonary hypertension, and develop COVID, they present sometimes aggravation, which don't solve so rapidly. But at this time, I don't know, Mark, if you have seen pure COVID, post-COVID pulmonary hypertension. It's very few. It's not the mass, but perhaps it will take time because you don't have this major disease directly after having thrombosis. Sometimes it needs some time to develop and to aggravate.
Yeah, we have to follow the cohorts, but obviously these are provoked thromboembolism and they are not the most likely causes of future pulmonary vascular disease. But we have to be open and to follow our patients very carefully. James?
Yeah, so perhaps another question from the audience, which is around, there's only so much that we can do via a video link. And so for conditions like pulmonary hypertension or interstitial lung disease, there are tests like the 6-minute walk test, for example, that would be part of assessment. So perhaps Marion, and then I would ask Katerina from an interstitial lung disease point of view, just say, how do you assess patients when you can't do the tests that you would normally do to assess the severity of disease?
That's a problem because we thought at a certain point to organize a 6-minute walking test at home, but it's according to other physiotherapists, it's probably a bit risky, and they prefer something which could become important in the future. It's a trap assay where they need to measure the number of traps they can put up and downs, but it's something which is very preliminary. And other centers are using activity measures, which is a surrogate of the exercise capacity of the patient. So this could be also a way to replace the 6-minute walk test in the future.
And Katerina, I'll ask you to comment on this as well, because the interstitial lung disease is definitely winning as a topic of questions on the Slido. So Katerina?
Yes, thank you for the questions. I agree with Marion. It is very difficult to access the patients with a 6-minute walking test by telemedicine. So we don't use that, but they have the pulse oximetry and they communicate to us when they feel differently, or they measure their oxygenation by pulse oximetry if they feel sick, or and then as we didn't stop because of the early lockdown, the outpatient clinic, we continue to receive and to have them in outpatient clinics and to continue the clinical trials and the early diagnosis of interstitial lung disease, and also to take in consideration now, and we have reorganized our ILD outpatient clinic also for the patients after COVID. And now we have a special clinic for post-COVID abnormalities. And I think respiratory physiology, pulmonary function tests with both FPC and DLCO are very important. It's a very important tool in our hands. And also as post-COVID, let's say, disease is both vascular and interstitial regarding physiology. DLCO is an important tool for post-COVID and returns to normal limits after FVC. So it is very important, the follow-up statement that we are trying to work now with within ERS, within a lot of assemblies, and Marion, of course.
Thank you very much. And yeah, the message very much is we need to be innovative when we're prevented from doing what we're used to doing. A final question, I think it would be nice to finish with a comment from our patient representatives and also from Pippa. What do you think is the key takeaway? What's the main lesson learned that you would like us to take away from the pandemic? Maybe if we start, Pippa, would you like to start, and then we'll go around our patient representatives.
So I think my key message is about access to information. I mean, I think, this is what ELF really focuses on, is working together with healthcare professionals and patients to find out what the patients want to know and what the evidence-based or the most reliable information of the time is. And the Q&A we did during the COVID pandemic was incredible, just watching all of the questions coming in and trying to find the best answer and the best evidence that we could. So I think finding systems and ways that we can inform and educate patients as accurately as possible and as quickly as possible, and giving patients access to experts as much as we can, is something that I really take away from this pandemic and hope we can continue afterwards.
That's great. And Pisana?
One lesson we can take is that the world is going increasingly digital, and I'm a bit worried about patients not all have the level of digital literacy that is required to be able to do telemonitoring or even meetings like this, to participate in all the things that are happening in the world that are digital. And my other concern is I think there will be mental health issues to address also.
Yeah, I think that's undoubtedly the case worldwide. Gergely, anything to add from your perspective?
Yeah, many thanks. Actually, I would like to echo what Pippa mentioned, that we are in big need of reliable information. And these unprecedented times show us that actually patient empowerment is very important. Once we need to have patients and partners in telemedications, because otherwise it is very difficult to follow up the condition of these patients.
Yeah, so that seems to be a recurring theme, that information is the key thing that people wanted. So we haven't talked about CF in this section. So Clémence and Isabelle, from a CF patient perspective, what do you think was the key piece of information that patients were looking for?
Well, I think in CF and in rare chronic respiratory or elsewhere diseases, the big thing we have is that we have motivated patients, and they are motivated to work with us. So to react to the first question of Marc when talking about the competitivity of academic studies on our rare diseases instead of COVID diseases, I think what we say in French is l'union fait la force. I don't know how to properly traduce it in English, but it's strength comes with the union, and the luck we have in rare disease is that we have patients and patients associations, and I think communication between each other, practitioners and patients, is very important. Communication from us to the patients, and the patients that can back up to us their problems. So I think l'union fait la force is what I want to say.
All of us together is a beautiful way to finish the evening.
Thank you very much, James, for this very clear concluding word. Thank you, everybody. We can see Katarina, so it's very, very good to be with you tonight. We wish we had not experienced that pandemic, but we had to cope with it, and we have learned so much. And I think that we need to think positive, and Next time we will be in peacetime, we will have to think about the next war zone we may face in the future. And I strongly believe, and that the reason why I wanted to have all of you around the table tonight, I strongly believe that patients, patient associations, doctors, and big societies like European Respiratory Society and networks like the European Reference Network for Rare Lung Diseases, they have demonstrated how good they are in responding as fast as possible to this dramatic crisis. So thank you so much for being with us. Thank you for working so hard, patients, carers, and doctors. And thanks to ERS for putting that session on in the spotlight tonight. So I will hand over to Maeve to conclude, and please stay safe in the next months.
Thank you, Marc. Thanks to the audience for joining us and participating in today's ERS Vision Live panel discussion. A recording of the discussion will be available to rewatch on the ERS Respiratory channel. And the ERS Vision Live series will continue. A new live discussion panel will feature on the ERS Respiratory channel each month, bringing together key individuals to discuss hot topic areas within respiratory medicine and science. We would like once again to thank our speakers tonight. We hope you can join us again for our next discussion.